Next lecture is about stage-dependent outcomes after laser therapy for twin-to-twin transfusion syndrome by Dr. Kurt Hecher, Medical Director, Center for Obstetrics, Pediatrics, and Juvenile Medicine, Chairman, Department of Obstetrics and Fetal Medicine, University Medical Center, Hamburg, Germany.
Okay, thank you very much. As I said, I'm going to talk about stage-dependent outcome after laser therapy for TTTS. Now remember that the main diagnostic criteria for TTTS are polyhydramnios in the sac of the recipient and anhydramnios in the sac of the donor, which means more than 8 centimeters before 20 weeks and more than 10 centimeters after 20 weeks for polyhydramnios and less than 2 centimeters for the donor. It's stage 1. It's a stuck twin, but the bladder is still visible. And this actually is the only difference between stages 1 and stages 2. At stage 2, the bladder is not visible any longer, whereas stage 3 shows severely abnormal Doppler findings, which is arrest flow in the umbilical artery or zero or reversed flow in the ductus venosus A wave, which is in the majority, the vast majority of cases, the recipient due to cardiac failure, and the arrest flow is in the majority of cases in the donor with unequal placental sharing. And stage 4 is hydros. I'm not going to talk about stage 5 because for me it doesn't exist. If one baby dies, there's no twin-twin transfusion syndrome anymore. It would be the same as if you would say stage 5 of ovarian cancer is death of the patient. Then it's death. It's not the stage of the disease anymore. Let's have a look at the bladder. I mean, you can see here 2 images taken 10 minutes apart. If you take the image on the left side, it's zero bladder filling. 12 minutes later, there is some bladder filling. So it takes time to look at the fetal bladder, and it depends whether you say yes or no, how long you look at the bladder, and what the dynamics are. Another example is this one. Would you call that a bladder filling? Yes, there is a tiny little bladder filling, but it's not very impressive. It's far away from normal. And 20 years ago or 15 years ago, we would have said no bladder filling. Now, if we look at the bladder very meticulously, then some will say there is a tiny little bladder filling, but nobody will question the diagnosis of severe twin-twin transfusion syndrome, as you can see here, with the tiny little amniotic fluid, which is left with the donor twin. So my opinion is, and I can show that if I show you the results later on, the outcome, that the bladder filling is a very soft marker for staging. And I will tell you at the end whether I would still insist on differentiating between stage 1 and stage 2 twin-twin transfusion syndrome based on a soft marker. Whereas, if you look at if you do the scan, you will immediately see that this is the typical sign of TTTS, massive polyhydramnios and the stuck twin. Due to hypervolemia and hypovolemia, and this is a schematic image, which is the typical appearance of twin-twin transfusion syndrome. But there is something which is very important and which is different from stages 1 and 2, and this is the Doppler at stage 3. And here you can see the typically abnormal Doppler in the recipient with reversal of flow during atrial contraction and zero flow in the umbilical artery of the hypovolemic donor twin. So that makes really a difference. And the typical signs for cardiac failure, which has just been defined as well in the previous lecture, is the abnormal waveform in the ductus venosus and double pulsations, even as you can see here in the umbilical vein, tricuspid regurgitation and mitral regurgitation. Whereas on the donor side, usually it is zero flow or reversal of flow in the ductus in the umbilical artery, which is typical for stage 3 TTTS. And this is due to unequal placental sharing. As you can see on the right-hand side, the donor has a marginal cord insertion and it owns only a very minor part of the placenta as compared to the recipient. If there are artery-to-artery anastomosis, then you can see these typical cyclical changes in the umbilical artery waveform of the donor, which can be propagated even very close to the donor fetus. And this is also then means an increased risk for fetal loss after you do the laser procedure, because the donor is left with this grotty part of the placenta. Now, that makes a certain or an impact on staging, and this is stage 3. At the end of the day, it's a combination between selective fetal growth restriction in monoclonic twins and twin-twin transfusion syndrome, but the same criteria apply for the difference in amniotic fluid as at stage 1 or 2. Now, this was a systematic review and meta-analysis which was published by this group, and it included publications which were published between 2003 and 2018 on the outcome based on quinterio staging. And overall, they found that fetal overall survival is higher for earlier quinterio stages 1 and 2 than 3 and 4. Neurological morbidity after laser was very low in this meta-analysis. It's about 4%. Now, if you look at the outcome for stages 1, 2, 3, and 4, you can see the double survival, which is the main outcome after laser for TTTS, because we're treating 2 fetuses, was significantly lower at stages 3 and 4 in comparison to 1 and 2, which are the black bars. They also looked at the outcome at stage 4. I put a question mark there. I mean at stage 5, because for me, stage 5 is not existing really. It's not twin-twin transfusions anymore. It's intrauterine fetal death of 1 fetus, and of course, you don't have any double survivors in this case. Whereas if you look at stage 1, based on different management options, the first group of bars shows expectant management, the second one laser therapy, and the third one amnio reduction. There were no significant difference in the outcome. But this is a very heterogeneous group, and that's what they had to admit as a limitation of this meta-analysis. Now, therefore, we looked into our follow-up in more than 1,000 pregnancies. We had 1,020 pregnancies, which we first of all analyzed as a group as the whole group. And you can see here that when we then divided them into groups of 200 and 220, the last group, you could see a significant increase of double survival for the consecutive time intervals from 50% to about 70%. Number 2, with the introduction of a specific 30 degrees fetoscope for anterior placentas, we could improve the double survival rate for cases with anterior placenta, so that they did not differ anymore for posterior placental location. Number 3, if you work in a center with a high caseload and you train young surgeons, they will have from the very beginning the same double survival rate as you as an experienced surgeon, because you are supervising them with each procedure and you can intervene immediately so that the patient or the fetuses don't have to suffer from the individual learning curve of a new trainee. So after that analysis, we then did the second analysis, and we looked at the population in terms of outcome regarding corresponding to different stages, stage 1 versus stage 2 and stage 3 versus stage 4, does not affect probability of double survival after laser therapy. So this is the main outcome of the study. It's already in the title. And if you look at the detailed tables, as you can see here, if we look at double survival and at least one survivor, there was no significant difference between stages 1 and 2. There was significant difference between stages 2 and 3, and there was no significant difference between stages 3 and stage 4. So therefore, we combined stages 1 and 2 and compared the outcome of stages 1 and 2 taken together with stages 3 and 4, and that the results you see here, that in terms of staging, The double survival rate is on the left side, and the survival rate of at least one twin per pregnancy is on the right side. It was significantly higher for stages 1 and 2, 71% versus 55%. Double survival rate, you can see it in this table as well. And on the right-hand side, at least one survivor for stages 1 and 2 was 90% versus 82.5% for stages 3 and 4. If you look at the double survival rate, or the survival rate of at least one survivor over time, so those are the 5 groups now of consecutive groups of laser therapy. The first 200, the next 200 up to 400, then up to 600, 600 to 800, and 800 to 1020, where we have the outcome of all of them except for one, which was lost. She came from the Middle East and was lost for outcome. This was the only one. You can see here that for stages 1 and 2, the rate for at least one survivor increased from 86 to 95. And for stages 3 and 4, from 76% to 88%. And this is how we counsel patients coming to our department for possible laser therapy nowadays. We tell them when they are at stage 1 or 2, the chance of having at least one survivor is 95% in our hands, and it is 88% if they are at stage 3 or 4 TTTS. And now the most important ones are the double survival rates, of course, because the parents come with twins and they want to have 2 survivors, which is understandable, of course. You could see that there was a significant increase for stages 1 and 2 from 60% to 75% over time. And for stages 3 and 4 from 42% to 62%. And this is how we counsel patients coming to our department for laser therapy. If they ask, what is the chance that I will have 2 babies surviving? It is 75% if you are at stage 1 or 2, and 62% if you are at stage, and 62% if you are at stage 3 or 4. So there are significant differences between 1 and 2 taken together and 3 and 4 taken together. Now at stage 3, you have to differentiate between stage 3 recipient with cardiac failure and stage 3 donor with an increased placental resistance and unequal placental sharing. If you look at stage 3 recipient, there's no significant difference between donor and recipient survivor. If you are at stage 3 donor, RF flow in the donor, there is a significant lower survival rate of the donor, because the donor is left with its tiny little part of the placenta, and therefore there's a higher rate of intrauterine fetal death. Only about 50% of these donors survive. There is no significant difference if both are at stage 3, recipient and donor. But on the other hand, if you look at stage 4, which is only applicable in 99% of cases to the recipient, because the recipient develops the hydrops due to cardiac failure and not the donor, the survival rate for the recipient is lower than for the donor, as expected. But still, 50% of recipients with hydrops survive. So there is no reason to perform feticide by cord coagulation in the first place for a hydropic donor. And you can see here that there was spontaneous remission. It was not spontaneous, but complete remission after laser therapy in a hydropic recipient, which showed ascites, as you can see here, and skin edema with a severely abnormal ductus venosus waveform. And look at the ductus venosus waveform 3 weeks later. It was normal. There was still an increased pulsatility, but positive flow during atrial contraction. And even the most severe abnormality with reversal of the complete reversal of flow in the right ventricle, retrograde filling via the ductus arteriosus at the pulmonary artery, and complete holosystolic tricuspid regurgitation. You can see here on this image, red is retrograde flow through the truncus pulmonalis, whereas it's blue in the aortic arch. there was spontaneous reversal and forward flow through the pulmonary artery, in this case, 1 day after laser therapy. Don't ask me how that happens, but it happens. In about 50% of cases, you have reversal a few days after the laser therapy of the pulmonary stenosis in the recipient. Now, then we performed a randomized study together with the Wills group and others. It was an international group, as you can see here, where we compared fetoscopic laser therapy versus expectant management at stage 1, TTTS. Now, expectant management meant expected management. This was not a comparison between laser therapy and amnio drainages, but laser therapy and expectant management, and only do the laser if there is deterioration of the TTTS staging. And overall, there was no difference in the intact survival rate between surgery and expected management overall. However, 41% of the cases managed expectantly remained asymptomatic and did not progress to higher stages throughout pregnancies. Vice versa, 59%, almost 60%, developed deterioration and developed maternal complications due to the polyhydramnios that we had to perform a laser in the second place. And in this group, with expectant management, intact perinatal survival was 86%, whereas it was 76 and 71% following immediate or rescue surgery. This was not a significant difference. So overall, there was no significant difference between expectant management and laser therapy in the first place. So the conclusion of the whole group was expectant management is a safe option at stage 1 TTS. I would add in selected cases, because you must not forget the exclusion criteria. The following criteria were exclusions, and which made it impossible to randomize or include this patient in the randomization process. Maternal symptoms related to polyhydramnios, like contractions, dyspnea, orthopnea, a short cervix of less than 15 millimeters, and both are simply part of the features of TTTS. And 50% of the patients who came to our department, for instance, could not be excluded at stage 1 because they showed this either a short cervix in the first place or maternal symptoms with massive polyhydramnios at the time where there was still a little bladder filling in the donor. So we could not randomize them. We had to perform the laser in the first place. So 50% you lose from the very beginning. And of the rest, only 40% of the other 50% remain stable, and 60% you have to do the laser in the second place anyway. Furthermore, before 16 weeks and after 17 weeks, we would not randomize them. And PPROM was an exclusion criteria as well. Now, this is the flow chart. I want to go further. You could see here there were 116 fetuses in the expectant management group and 118 in the immediate laser group. The only significant difference was that the rate of premature rupture of the membranes before 32 weeks was higher in the immediate laser group, which is not surprising because the fetoscopy per se increases the rate for PROM rate. And in the expectant management group, there were 40% which didn't need the laser at the end. So therefore, you have this significantly higher rate in the laser group. If you look at the laser group, at the expectant management groups and compare the two arms where there was a progression versus no progression, in the progression group, you had to do rescue therapy. And there was a significant difference in the overall survival in terms of 2 fetuses, which is logical because if you do the laser then you will have a higher rate of donor fetuses dying in the case where there is stage 3 donor TTTS. But overall, at the end of the day, there was no significant difference between the two groups. As you can see here, and this is the time interval between randomization and delivery. The red line is the laser group and the blue line, the expectant management group. But never forget that in the expected management group, at the end of the day, we had to perform laser in 60% or 59% exactly, because only 41 remained stable. Are there any prognostic factors for disease progression in patients initially managed expectantly? That would be helpful, because then you could say, well, it's not worth to manage you expectantly, because if you have this factor which shows that there will most likely be a progression in the disease, then you could laser in the first place, but there are none. You can see there is no significant variable which will show you a high likelihood for progression at stage 1. So overall, the trial has shown that expectant management with heightened weekly surveillance is reasonable without compromising the outcome of 59% of cases that will progress and require surgery. However, this option is restricted to a selected population of stage 1 cases that present with no maternal symptoms, a long cervix, and have access to a surgical center within 48 hours. Now, if these patients come to us as an experienced center for laser therapy, we counsel them about the results of that study. 50% have to be lasered anyway in the first place because they have maternal complications or a short cervix. And the other one tell us, well, now I'm here, and now you're going to tell me, you wait, I go home again, and then I have to come again. And in 60%, you will have to do the laser anyway. Almost 100% of those cases decide to have the laser in the first place. So the end of my lecture is to answer the question, does it make sense to distinguish between TTTS stages 1 and 2? According to these results and my own experience or our own experience, I would say rather not, because this is a soft marker, whether there's still bladder filling or not, and there's no difference in outcome between stages 1 and 2. 1 and 2 is different to 3 and 4 taken together. Thank you very much for your attention.
Thank you very much, Dr. Kurt. Any question? Any question?
Thank you, Professor, for your interesting talk. But you mentioned short cervix 1.5 cm. We used to call short cervix at 2.5 cm to do circulation and pregnancy.
Yeah.
If it's shorter than 2.5 cm.
Okay.
You said 1.5.
Yeah. If you do that, you can do it, but you will have more in the first place, which you have to laser immediately. So that was the opinion or the consensus of the whole group participating and working on the protocol for that study, that we said, of course, the cervix is very short in cases of TTTS anyway. Therefore, we opted for 15 millimeters. And as you can see, half of them cannot be randomized, or you cannot wait anymore because they have severe maternal symptoms or a short cervix defined as below 15 millimeters already when they come with TTTS in your department. If we would have chosen 25 millimeters, almost none of them, maybe 20 to 30%, could have been randomized.
Question away from this talk. When to do circulation for single, at 12 weeks, but short cervix at 2.5 or minimum what?
Well, in twins in general, it's still 2.5, yeah, 25
Not twins,
millimeters.
We can't habitual abortion.
Sorry?
For single baby. Single baby. Single pregnancy.
With singleton.
If singleton. Yeah.
Single.
25, yes, 25 millimeters would be the cutoff.
Triplet. or triple gestation.
It's difficult to understand here because
Triple, three babies. Triple. You do
there are
circulation
no
or
normal values for triplets. I mean, because you won't have so many triplets where you can calculate normal values for the cervix for triplets. They are at very high risk for premature labor and premature rupture of the membranes anyway.
No need for evaluating cervix. You do circulation empirical, but some people do empirical circulation for triplets.
Cerclage
Yes,
for triplets.
yes.
In general, no, we don't do it.
You don't.
Not in general, no.
Okay, thank you.
And certainly not in twins.
Thank you very much, Dr. Kurt.
Thank you.